Welcome to online anesthesia video of the week. Today topic on low flow anesthesia is presented by Dr. J.Edward Johnson, Professor and Head of the Department of Anaesthesiology, Kanyakumari Government Medical College. He is an Associate Editor of Indian Journal of Anesthesia and past President of ISA Tamil Nadu State. His love and interest on teaching through social media makes him being Chief Editor of online anesthesia teaching programs.
Morning and warm welcome to online anesthesia. Today we are going to see the low flow anesthesia principles and practice. Myself, Dr. Edward Johnson, working as a professor and HOD of Department of Anaesthesiology, Kanyakumari Medical College. So what are the basic needs for a low flow anesthesia? We need a vigilant anesthesiologist, best anesthesia machine and good monitors to perform a low flow anesthesia. So let us walk through the history of low flow anesthesia. In 1850, John Snow proposed a concept of rebreathing of inhalation agents could reduce the narcotics requirement. Subsequently, in 1924, Ralph Waters introduced to and fro canister, that is carbon dioxide absorber in the anesthesia practice, and that bring a boost to the practice of low flow anesthesia. Following that, in 1936, Brian Sword introduced a circular absorber system for carbon dioxide absorption in the practice of anesthesia, and it further boosted the concept of low flow anesthesia. But in 1954, after the introduction of halothane, there is a stagnation in the concept of low flow anesthesia because the halothane needs high flow. And subsequently, the introduction of tech series and halothane cassettes, vaporizers in the anesthesia practice, and following that, introduction of the newer anesthesia machines like Trager Precious A500 Apollo and GE Health Aspire View and Avant CS2 with EcoFlow. This Avant CS2 EcoFlow has a separate system to deliver the low flow anesthesia. Coming to the definition of Baker's modification of Simonis classification, if the fresh gas flow is more than 4 liters, it is called very high flow. If it is 4 liters, it is called high flow. If it is 2 liters, it is called medium flow. If it is less than 1 liter, it is called low flow anesthesia. If it is around 0.5 liter, it is called minimal flow. And if it is equivalent to 0.25 liter, that is 250 ml of oxygen taken every minute, then it is called metabolic flow. So the basic concept is when the fresh gas flow is below the minute ventilation, it is called low flow anesthesia. When you recirculate the expired gas, 50% of the expired gas, it is called low flow anesthesia. Why we have to practice low flow anesthesia? Because low flow anesthesia, there is a low wastage of inhalation anesthetics, and so that there is low expense on the inhalation anesthetics cost. And also it is safe to the theater environment or also the environment, and it is planet friendly and it warms the patient and moistens the carbon dioxide absorbed. So what are the different types of low flow anesthesia? So anesthesia with low fresh gas flow is divided into semi-closed rebreathing system and closed rebreathing system. In the semi-closed rebreathing system, there are two types. That is low flow anesthesia, that is flow is equal to 1 liter per minute. The minimal flow anesthesia, when the flow is equal to 0.5 liter per minute. In closed rebreathing system, there are two types. That is closed system anesthesia, quantitative closed system anesthesia. In closed system anesthesia, if fresh gas is equal to the volume of the gas taken by the patient. Suppose the patient is taking 200 ml of oxygen per minute and 300 ml of nitrous oxide per minute, you replace the fresh gas flow of 500 ml with a different composition. But in quantitative closed anesthesia, if the patient is taking 200 ml of oxygen and 300 ml of nitrous oxide per minute, you replace exactly the same ratio, 200 ml of oxygen and 300 ml of nitrous oxide. That is called quantitative closed system anesthesia. So coming to the circular absorber system, why it is called circle? Because during inspiration, the gas goes into the patient and the expired gas goes partially into the atmosphere and partially into the rebreathing system. So the oxygen and the inhalation anesthetics are rebreathed and carbon dioxide is absorbed. So it is added to the fresh gas flow and once again it is inhaled. So it goes in a cycle. So it is called circular absorber system. So coming to the theory, if there is high flow, if the fresh gas flow is more than 4 liters, there won't be any rebreathing of the gases. If it is 2.5 liters, there will be 52% of the expired gas will be rebreathed. If it is 1 liter per minute, there will be 86% of the expired gas will be rebreathed. In minimal flow, in 0.5 liter, 97% of the expired gas will be rebreathed. And closed circuit, if the first gas flow is 0.3 to 0.5 liter, there is absolutely 100% rebreathing of the expired gas. So in low flow anesthesia, the hypoxia can happen, but we have to do all the measures to avoid it. There is one question, that is, if you are using a standard anesthesia machine and everything works, even including the carbon dioxide absorption, and the first gas flow is equivalent to 1 liter of air, no other flow of first gases, the patient is awake and breathing, will the patient live or die? Assume that the oxygen consumption is 0.25 liter, that is 250 ml per minute. So the experiment was carried by the James Hutch Philip, and they found that they started the experiment with 80% oxygen in the circuit, and as the time progresses, there is a fall in the FiO2 and it reached 8%. The experiment was discontinued and patient was given 100% oxygen to revive. So the uptake of inhalation anesthetics, or there are two types: zero order elimination kinetics, it is called a Linz linear model. Here the uptake of anesthetic gas is near constant. Like oxygen, the uptake is 250 ml per minute is a constant. In first order elimination kinetics, that is according to Lowi's theory, the uptake decreases exponentially with the time. So this is the formula: 1 divided by alpha equal to square root of time. So in uptake of oxygen, the both has occurred. Initially the first order kinetics and followed by zero order kinetics. So the FiO2 reached 8%. If it's interpolated, it will reach up to 0%. So the experiment was discontinued. This is quick recovery with 100% oxygen. So the strategy for minimal flow anesthesia, you have to add to the circuit the amount of the anesthetic taken by the patient. Suppose the patient has taken 250 ml of oxygen, you have to add 250 ml of oxygen every cycle. For that, we must know the uptake of each gases per minute. So according to Brody's formula, the uptake of oxygen is 3.5 into body weight. It is constant throughout the inspiration, throughout the cycle. So the uptake of nitrous oxide, according to the Schrodinger's formula, if the patient is inhaling 70% of nitrous oxide in a 70 kg patient, the first minute uptake will be 1000 ml, and for subsequently it will be reduced to 200 ml per minute uptake of after 25 minutes, then 140 ml per minute after 50 minutes, and 90 ml per minute after 2 hours. So there is a decrease in the uptake as the time progresses. So the uptake of inhalation, we can use this Lowi's formula, that is F into MAC into blood gas solubility into cardiac output into time power of minus R. So the uptake of gases, oxygen uptake is constant. 2 ml per minute means throughout it is constant. But in coming to the inhalation anesthetics, initially it is high. As the time goes, it falls. It is exponentially decreases according to the time. So this is also exponential fall of inhalation anesthetics according to the time. So what is the net fresh gas flow? Net gas fresh flow means the concentration of the anesthetic gases in the inspiratory breathing circuit, inspiratory limb of the breathing circuit. It depends upon three factors: the inhalation anesthetics taken by the patient and replaced by the fresh gas, and also the rebreathed oxygen and anesthetic agent. So the net flow should be equivalent to the fresh gas flow minus the patient uptake. If it is oxygen, 200 ml. If it is nitrous oxide, depending upon the time, is 100 ml per minute. So to avoid hypoxia, you have to use in FiO2 of 40 to 50% in low flow anesthesia, 50 to 60% in case of a minimal flow anesthesia. So coming to the practice of low flow anesthesia, how to perform low flow anesthesia? So if you are using intravenous induction, it takes a longer time for the anesthetic gases to reach the desired alveolar concentration. Suppose you are using inhalation anesthetics as an induction, you have to follow this any one of the 4 steps. There are 4 methods to achieve a quick induction of inhalation anesthetics. One is use high flow for a short time. Second is to use pre-filled anesthesia circuit. Third is to use large doses of anesthetic agents. And fourth is the injection techniques. We will see one by one. Use of high flow in the initial phase. It usually lasts for 10 to 20 minutes. In case of here low flow anesthesia, it lasts for 15 minutes. In case of here minimal flow anesthesia, it lasts for 20 minutes. So the gas flow, initially, you have to keep a fresh gas flow of 4 liter with component of 1.5 liter of oxygen and 3 liter of nitrous oxide. Then you coming to the vaporizer setting, you use a vaporizer setting of halogen 1 to 1.5, isoflurane 1 to 1.5, sulfurane 2 to 2.5, enflurane 2 to 2.5, and desflurane 4 to 6. So the first 10 to 15 minutes, what happens, the expected concentration will slowly increase and achieve 0.8 max. If you add nitrous oxide, it will add 0.5 max, 0.6 max, so totally you will get a 1.4 max. So the low flow anesthesia initial phase should last for 10 minutes. In minimal flow anesthesia, it should be extended for 5 more minutes to 15 minutes. Coming to the second method, that is pre-filled circuit, you use vehicles for pre-oxidation and simultaneously you fill the breathing circuits with the desired anesthetic concentration. Once the intubation is done, you connect this pre-filled circuit to the patient, so you can quickly achieve the breathing circuit concentration. So the third method is use large doses of anesthetic agent. The first we have seen high flow and low vaporizer concentration. Here we are going to give a high vapor concentration and low flow. So the usual requirement of the first 10 to 15 minutes is the 400 to 500 ml of vapor we need. So average need of 40 to 50 ml of vapor per minute in the first 10 minutes. So you have to set a vaporizer setting of 5% for a fresh gas flow of 1 liter. You will get 500 ml of vapor. And fourth method is directly injecting the inhalation anesthetics into the breathing circuits, inspiratory or expiratory, through a special plastic seal rubber diaphragm. On theory, 1 ml of halogen gives 226 ml of vapor and 1 ml of isoflurane gives 196 ml of vapor. In first 10 minutes, we need 500 ml of vapor. So you need 2 ml of the anesthetic agent. It should be given in a small packets. Or you can directly calculate the exact dose of priming dose depending upon the formula, that is desired concentration into FRC plus circuit volume into cardiac output into blood gas coefficient. So coming to the time constant, what is time constant? Suppose you are giving 1% vaporizer settings, the time taken for the inspiratory limb of the breathing circuit to reach the 1% is called time constant. Suppose you are changing 1% to 2% in the vaporizer setting, the time taken for the breathing circuit to reach the 2% concentration in the inspiratory limb of the breathing circuit is called time constant. So the ideal anesthetic gas for low flow anesthesia is sevoflurane and desflurane because they have a short time constant. Once you change the concentration in the vaporizer setting, it quickly reaches the same concentration in the inspiratory limb of the breathing circuit. So what happens in high blood gas solubility? They have a long time constant. That means the amount of the gas that goes into the patient is more, so the less anesthetic gas comes into the expired limb and it gets diluted by the fresh gas flow. So the expired concentration is low. So it takes a long time to reach the expired concentration in the breathing circuit inspiratory limb. So it is called long time constant. What happens in the low blood gas solubility anesthetic agent? Less gas is taken by the patient, so more anesthetic gas in the expired limb. So more is rebreathed and it quickly reaches the expired concentration in the inspiratory limb of the breathing circuit. So it is called short time constant. That is your desflurane and isoflurane. They are ideal for the low flow anesthesia. Suppose you are using low solubility first gas flow, this less taken, that is the same concept I have already discussed. Less solubility, less taken by the blood. The expired gases has more anesthetic agent. So the expired anesthetic concentration quickly reaches, and also the expired anesthetic concentration follows the vaporizer settings. Induction can be done by two methods in this flow rate. But initially, you can keep a high flow and low vaporizer settings to reach the anesthetic vapor of 500 ml in the first 2 minutes, or you can keep a low flow and high vaporizer anesthesia settings to reach the inspired concentration in the inspiratory limb of the breathing circuit. So the catch is, using a first gas flow of 5 liters, a vaporizer setting of 1%, you will get 500 ml into 0.01 means 50 ml per minute. Suppose you are keeping 1 liter per minute, what is the vaporizer setting you have to keep to get 50 ml per minute? So obviously 0.05, that is 5%. Suppose the first gas flow is high, you can keep a low vaporizer setting. If the first gas flow is low, you have to keep a higher vaporizer setting. So all over the world, 5 is into 1 is equal to 1:5. So coming to the flow reduction, in low flow anesthesia, reduce the first gas flow to 1 liter per minute after 10 minutes. To maintain safe inspiratory anesthesia concentration, you have to keep 30% in the low flow anesthesia and 40 to 50% in the minimal flow anesthesia. So during maintenance, you have to constantly observe for the inspired oxygen concentration. If the inspired oxygen concentration falls, initially you have to keep 40 to 50% in the low flow anesthesia, 50 to 60% of FiO2 in minimal flow anesthesia. If the monitor, you have to continuously monitor the FiO2. Suppose the FiO2 falls below 30%, what you have to do is, you have to increase first gas oxygen flow 10% of the total gas flow, and simultaneously you have to reduce 10% of the nitrous oxide flow, this, in the first gas flow. Or otherwise, if the red alarm blinks of low flow, low FiO2, then you have to do is, in low flow anesthesia, you increase the oxygen flow to 100 ml per minute, simultaneously reduce the 100 ml of nitrous oxide, and in minimal flow, you increase 50 ml per minute of oxygen and simultaneously decrease nitrous oxide 50 ml per minute. So maintenance phase, suppose you want to increase the depth of anesthesia, what you have to do? If the short time constant, you have to increase the inspired oxygen concentration to increase the depth of anesthesia. Suppose you want to decrease the depth of anesthesia, you have to increase the first gas flow. Thereby, you can decrease the inspired anesthetic concentration in the inspired limb of the breathing circuit. So the effect of first gas flow and the rebreathing and circuit concentration is, suppose in high flow, if you change in high flow, that is 5 liters per minute, there is no rebreathing. If you keep the vaporizer setting 1%, after 1 hour, the vaporizer setting in the inspired limb of the breathing circuit will be the same, 1%. But in case of 2.5 liter per minute, if you keep 0.94% of anesthetic vaporizer setting, you will get 1.1% in the breathing circuit after 1 hour. So the vaporizer in the breathing circuit slowly increases because of the rebreathing of the anesthetic gases. If it is 1 liter, there is more 86% of the rebreathing. So if you keep 0.68% in the vaporizer setting, after 1 hour, the breathing circuit will be increased to 1.4% because of the rebreathing of 86% of the expired anesthetic gas. Likewise, in 0.5 liter, if you keep 0.54, after 1 hour, the breathing system concentration increases to 2%. In closed circuit, 0.5 liter per minute, there is 100% reabsorption of the expired gases. So if you keep a nitrous oxide of 0.52, after 1 hour, the nitrous oxide concentration in the inspired limb of the breathing system will increase to 2.4%. So the alarm settings you need for low flow anesthesia is, you have to use a inspired oxygen concentration low alarm setting of 30%. And disconnect alarm, you have to set a peak inspiratory flow disconnect alarm of 5 centimeter of water because we are using very low flow anesthesia. And minimal volume monitoring also is must. You have to keep a below nominal value of 0.5 liter per minute. The inspired volatile anesthetic concentration upper alarm limit is must because as the time goes, the anesthetic concentration, the breathing circuit slowly increases due to the rebreathing. So in case of halogen, enfluorine, isoflurane, you have to keep 2.5% volume percent, and sevoflurane 3.5%, and desflurane 8%. So coming to the recovery phase, you can augment the recovery by various methods. First, you have to do is 15 to 20 minutes before the end of the surgical procedure, you have to switch off the vaporizer. Then 5 minutes before the extubation, you have to increase the first gas flow to high flow to wash out the anesthetic gases. Or you want more quick recovery, you can connect activated charcoal. That is, charcoal heated to 220 º absorbs the potent vapors almost completely. So you have to attach this activated charcoal canister with a bypass is placed in the circuit at the time of recovery. Coming to this equipment needed to conduct the low flow anesthesia. So the equipment needed to conduct a low flow anesthesia. Nowadays, the market is flooded with newer workstations with higher end sophisticated, mainly dedicated for the low flow anesthesia. Here is the aspire view. First, we need a vaporizer which is pressure compensated, temperature compensated, and flow compensated. Tech series vaporizers. And second, the flow rate should be in electronic or in a glass tube. If it is in a flow meter, there should be a separate flow meter for a low flow anesthesia. That is 2 flow meters available for oxygen, 2 flow meters for nitrous oxide. Or it should be a electronic process. The leakage rate should be in the breathing circuit should be less than 100 ml per minute. And fourth thing is that the first gas flow compensation should be available in the anesthesia workstation. And there should be a anesthetic gas reservoir. And also there is the breathing system has a minimal internal volume. So these are the prerequisites for a low flow anesthesia. So coming to the fresh gas flow compensation, there are 3 types available in the Trager machine. One is fresh gas decoupling valve. In decoupling valve, during inspiration, the fresh gas flow goes into the reservoir bag and comes into the ventilator in next expiration cycle for the next inspiration. In electronically controlled fresh gas compensation, there is a feed loop system, that is closed loop system, that constantly observes the volume of expired gases, and if the tidal volume falls below the set tidal volume, it will be added, additional gases will be added to the tidal volume. Suppose you keep a 500 ml of tidal volume and the expiratory limb there is only 450 ml and 50 ml is lost in the breathing system compliance, then the additional 50 ml will be added to the next tidal volume. So it is the flow compensation. So it is a must for the low flow anesthesia. So anesthetic gas reservoir, there are 3 types of anesthetic gas reservoir to monitor the tidal volume deliver. So manual bag, floating bellows, and reservoir bag. So coming to this ACCS2 anesthesia care station, here there is, you need to set only the expired tidal volume anesthetic concentration. So ET O2 or ET anesthetic concentration you have to set. The machine itself adjusts the fresh gas flow to reach your set end tidal oxygen or end tidal anesthetic gases. And here you have to set only the fresh gas flow. Suppose fresh gas flow you want to set 1 liter, you have to set 1 liter. It will adjust the FiO2 itself to 50%. So coming to the Drager Apollo low, it has a special low flow visa. Here it will constantly observe the fresh gas flow, whether and it displays whether the flow is appropriate or high or low. I say low as red signal and appropriate green signal and high as say yellow signal. So coming to the Dragon procedure A500, here also it adjusts the first class flow and the vaporizer anesthetic concentration according to the set end-tidal anesthetic gases. It is more advanced for the low flow anesthesia. It is, you can say it is a milestone in the anesthesia for low flow anesthesia technique. So coming to the, I already told you, you have to set the inspiratory oxygen concentration 30%, airway pressure of 5 centimeter of water, and anesthetic gas concentration in the circuit. There should be an alarm, and also the expired carbon dioxide concentration, because the soda lime is quickly exhausted in case of a low flow anesthesia. So the carbon dioxide concentration, expired concentration should be closely monitored. So advantages of low flow anesthesia is there is your reduction in the fresh gas flow. So gases like oxygen, nitrous oxide, and inhalation anesthetics. And the expired gas is circulated through the soda line. There is increase in the humidity and warmth. So you can maintain the body weight, and you can prevent post-operative shivering, and also you can prevent airway and bronchial drying. So coming to the cost reduction, if the fresh gas flow is high, the cost of the sevoflurane and desflurane isoflurane is high. If the flow is, you can reduce the cost effect. And coming to this, the theater, you can reduce the pollution of the theater atmosphere drastically to 15 ppm if you use a minimal flow anesthesia from high flow anesthesia of 122 ppm. Definitely it has environmental benefits because of the low inhalation anesthetics vented into the atmosphere. But there is unwanted gas accumulation in the circuit because of the low flow. There will be accumulation of the argon, hydrogen, methane, nitrogen acetone, and carbon dioxide and haloalkenes in the carbon dioxide absorber. So there is the carbon dioxide absorber get reacted to the inhalation anesthetics and produce carbon monoxide and compound A. So how to avoid this formation of the compound A and carbon dioxide? So if you use ordinary soda lime, there is a chance of accumulation of hydrofluoric acid and bromochloro difluoroethylene in case of calathane, and carbon monoxide with barolime. And if you use sevoflurane in low flow anesthesia in sodium, that is your soda lime, there is a chance of accumulation of compound A. That's why the FDA limit usage of sevoflurane as a carrier gas above 1 liter per minute. In Canada and India, they limit it to 2, and UK there is no limitations. And when you use low flow anesthesia, the consumption of soda lime is also increased 4-fold. That's why they have introduced newer carbon dioxide absorber like Dragon. They does not contain strong alkali, so they does carbon monoxide or compound A. They eliminates the decomposed formaldehyde and has a high carbon dioxide absorption capacity. So answer is also like that. It does not generate carbon monoxide, does not generate compound A, and does not generate formaldehyde with sevoflurane. And additionally, it preserves its color change once it's exhausted. And it carbon dioxide absorption capacity is also higher compared to the soda lime. So disadvantage of low flow anesthesia. So these are the places where we cannot use low flow anesthesia. That is short term anesthesia. If you are giving anesthesia with face mask, or a procedures like bronchoscope, rigid bronchoscope, where gas tight airway is not possible. Here you cannot give low flow anesthesia. And also if you have unsatisfactory equipment, you cannot give a low flow anesthesia. And inadequate monitors, malfunction of the oxygen measuring devices, in that cases also you cannot give low flow anesthesia. So coming to the end of this presentation, low flow anesthesia is simple way, you can say it is a mathematical art of volatile anesthetics. So if you want to be a anesthetist like this, who keeps always his fingers on the flow meter, then low flow anesthesia is your cup of coffee. Suppose if you want to be anesthetist like this who is enjoying a cozy sleep while the machine does its duty, then low flow anesthesia is not your cup of tea. So the low flow anesthesia, we need a vigilant anesthesiologist, advanced workstation, and a good monitors. Thank you. Thank you.